you. My name is Janice Tolentino. These are my partners, Teresa Hermisura and Jane Underwood, and we'd like to present to you our skincare bundle. We use the 8 A's model of evidence-based practice to guide us in this project. And what we found on our unit is that we had an increased amount of HAPIs, or hospital-acquired pressure injuries. As we know, it impacts patients because it increases their experience of pain, may increase their length of stay in their hospital admission, increases the risk of infection. It also impacts the nursing workflow because then we're implementing more things to help manage a wound. It reflects on our quality, which ultimately reflects on the organization and reimbursement. Majority of HAPIs are preventable, and according to current literature, per patient it may cost the organization about $40,000 for when patients experience HAPIs. Which leads us to our PICO question. Among 4 East and 4 North Progressive Care Unit oncology patients, will the implementation of the skin bundle compared to current practice decrease the occurrence of HAPI within 3 months of implementation? There is a lot of literature in regard to HAPI prevention, and from our readings, there's no one intervention that's the key to preventing hospital-acquired pressure injuries. Evidence strongly suggests that use of a bundle of interventions is what will help us improve our outcomes. In addition, nurses are aware of all these interventions, and we use them sporadically throughout our workflow, so the use of our risk assessment to help us focus our interventions also helps. And to help us in sustaining our outcomes, we also need grounding and leader champions.
So prior to the implementation of this project, we have about 7 hospital-acquired pressure injuries from January to May of 2018. So we created this skin algorithm in which there's a step-to-step procedure in which the nurse has to follow if the patient has impaired skin integrity, or if the Braden score is 18 or less, then they have to initiate the skin bundle. So I created this poster that is posted on our wall in our 4 E's. So the use of skin, SSKIN, to manage and prevent pressure injuries. So S stands for skin assessment, wherein 2 RNs do skin check assessment during change of shift. So we incorporated this during a handoff, in which the nurse has to check the skin together and check the most vulnerable pressure points of the patients. Together is to check all the possibility that the patient has some skin problems. The second S is about surface, in which we want to make sure our patient use the appropriate mattress or the use of the Ziploc positioner or any supporting devices for the patients, and appropriate linens or pad for the patient, including the special bed if needed with our wound specialist. K stands for keep moving or turning, in which we want our patients to be turned every 2 hours, and if they are in a chair, they need to be shifted their weight every 15 minutes, and we encourage them ambulation and with the help of our physical therapists to increase their ambulation if needed. I stands for incontinence, wherein we want to make sure our patients are kept clean after soiling and to keep the skin barrier protective devices. We increase use of the incontinent devices for the males, like the condom catheter and the urinary pouch. For the female, the Pureed, and for the GI incontinence, the Flexicils. We utilize also the Mepilex sacrum, in which any Braden score between 18 or less, we need to apply the Mepilex sacrum for that patient, in which that is being checked every shift, and it needs to be changed every 3 days. And last but not the least, and for the nutrition under the bundle, is to want to make sure our patient have the right nutrition to prevent injuries, and that we need to consult the dietitian any Braden score of 18 or less.
Okay. We've been using the Braden scale for predicting pressure sore risk in patients, and as we know, patients that score 18 or less would be incorporated into our skin bundle, qualifying them. What we were seeing in the initial phase prior to rolling this out and at our first staff meeting on July 2nd was that there was some inter-rater reliability discrepancies, particularly from shift to shift on the use of this tool. So what we did not want was patients to be underscored and inappropriately included in the bundle. They didn't require these interventions, nor do we want them overscored and then not be captured with these interventions that we needed. So we did have to address that initially. And what we found as we went through the project and we were collecting our data was some of the nurses were not looking at the patients as a whole in terms of their hospital stay. It's more of a snapshot view. So we had to re-educate on the actual proper use of this tried and true rate and score and scale so that they would look at the patient's mobility and nutrition across the hospital stay, not just in the initial hours of their shift before they actually did their assessments. With the help of Maria Teresa and Jeline, who is our mentor, we came up with this comprehensive audit tool for our what we called our mega audit that we did every month. This was, and it may look very simple, this we actually mathematically calculated compliance across the various domains of our skin bundle on the patients that were scoring 18 or less on our skin rounding log. And what we would first do was audit the chart and look at the charting and see what the documentation reflected, and then we would actually go do a visual inspection of the actual patients to see if these measures were being carried out. And many times we would see measures being carried out, but the documentation wasn't there. So we had to really emphasize to our staff that they needed to document all these measures that we were doing to protect our patients from the hospital-acquired pressure injuries. And as you can see, our outcomes speak for themselves. You can see we rolled out this project on July 2nd from June until the end of October, which is already the end of the data we collected. We've had this whole project is proving to be quite efficacious in that we now have had 0 hospital-acquired pressure injuries since implementation of the project. And our implications of significance was we've seen a significant change in the culture among our multidisciplinary team. And this is it's a collaboration not only among nursing staff, and that nurses are RNs and our CNAs, but also our interdisciplinary team, our physical therapists, our registered dietitians, because all of our patients included in the skin bundle automatically will have a registered dietitian on board. So to make sure that the nutritional assessments are done. And we're noticing our nurses are improving their accuracy of doing the skin assessments. And one of those things, as mentioned by Teresa, is there's a skin-to-skin handoff at every bedside report. And the skin is inspected from the outgoing nurse and the incoming nurse. And we've also done interventions in terms of teaching the staff one-on-one. At a recent hospital-wide collaborative council meeting, which is our hospital unit-based practice council, we shared our project, and unanimously the units all voted to adopt the skin bundle on their units as well. So in December of 2018, hospital-wide education will begin, and in January 2019, they'll go live as we did in July, back in July. And here are references, and scholarly literature, high level of evidence, and great thanks to our chief nursing officer, our director of acute care, manager, and all of the hard workers who actually did the work on the ground level.